Thank you very, very much, everybody. It's absolutely great to be here. Thank you so much, especially to Rosaline and the team in Amyloidosis Ireland for asking me to speak today. So my talk is a bit more down to earth, away from the lofty heights of the Royal Free and Queen Square. And it's really what I wanted to focus on today was where the services are locally here in the Northwest, what we have in place, what we'd like to have in place, and basically where the land lies more locally. Now again, my colleague Cathy Farrell will speak about what's happening in Donegal. So I know I was asked to speak about the Northwest, but there's a big chunk of the Northwest I'm not privy to the services. So I'll talk more about what's happening locally here on the northern side of the border. So what has changed since we chatted last in 22? Not enough is the honest answer. Of course, my glass, I try my best to have my glass half full, but if you work in the NHS, and I suspect it's not much different working in the public sector in the Republic, every day is a wee bit like walking through a field of quicksand, in that you're trying to do your best, but there's just things coming at you from all directions, and amyloidosis is just a very small part of those things in my working life. That's been hopefully it will be made easier, but more recently, very recently, we've had the onset of EPIC, so we've moved to a fully digital computerised system for healthcare in Northern Ireland, which has its challenges, particularly when you're 50 and you're not particularly computer savvy. And secondly, we've had a move to a regional lab service, which has also created challenges for us, particularly in this field. And it's very, very easy, again, when you're looking back on things, to say, well, what has changed? Has anything changed at all? And it's only by taking a good reflective look at things that I've been able to say, well, no, things definitely have changed. There are definitely improvements in things. But again, it's never, I don't know if it's never going to be enough, but it's not exactly where I would like it to be. But my what gets me up in the morning is to try to improve locally the patient journey for this condition. So again, as Professor Riley has said, and I know very eloquently, we're talking, I'm a cardiologist by trade, but I do see obviously amyloid patients who don't specifically just have cardiac issues, but we're talking specifically today about TTR amyloid and about AL amyloid. So AL amyloid from your bone marrow making too many light chains, TTR amyloid from mainly your liver making too much of this protein and it degrading in your system and your body doesn't know what to do with it. We have a lot of, I suppose, when you're looking for one condition, so I'm sort of specifically trying to find people with variant or genetic TTR locally, because we know we have a high genetic preponderance to the condition locally. As a result of that, we then pick up more patients with wild type TTR who don't have the genetic variant, so that, it's as a consequence of that. Now, you'll see, you've already seen a variant of this slide. You will see variants of this slide in every other talk today. But and this is the non-invasive pathway developed by Professor Gilmore and his colleagues in the National Amyloidosis Centre in London. The reason why I'm using this sort of as a template for how we go about and what diagnosis we use, the pathway that I use locally. So the very, very first thing about treating patients with amyloidosis is diagnosing the patients with amyloidosis. And as we've already said, so enhanced awareness of this, really I've seen as one of my major jobs in the last few years. I have literally I've lost count of how many talks I've done locally to my general practitioner colleagues, all variants of hospital doctors locally, my heart failure nurse colleagues regionally and through the whole of Ireland, and other cardiologists. And the pickup rates are definitely improving. The other way that I get patients sent to me as query amyloid are from my cardiac physiologists in the echo lab. So, they're very, very good at picking up these people as potential amyloidosis patients. And then again, links with my MRI colleagues regionally who will send patients to me, links with the haematologists who have patients who they think have AL amyloid who have cardiac issues, and all the other subspecialties. Now, in my practice, that's mainly neurologists and gastroenterologists who are the two groups of clinicians who send me query patients. So what do I do then? If I have a patient sent to me and we're querying that they have either form of amyloidosis, the first thing that I'll do is organise a very urgent appointment for them in the cardiology hub here in Altnagelvin, or the assessment unit in Oma, or the unit in the SWA. All the patients will get basic things like ECGs, their blood pressure sitting and standing, and their blood. Now, the most important bit of this then is the blood samples, and that's different from the National Amyloidosis Centre model has DPD higher, but we'll talk about why that's not possible. So it's important to get the right blood tests done. And if you send patients for just for protein electrophoresis, that isn't good enough. We need protein immunofixation, serum light chains, and urine protein immunofixation. Now, we've had big problems locally recently with the lab services, so apologies to any of you who are caught up in that. Wasn't of my doing, wasn't of Dr. Gray's doing in the Southern Trust either, but we had a lot of lab samples that were rejected. And for amyloidosis, I've had talks with the regional labs. The really important thing in Northern Ireland is if you don't put query amyloid on a urine form in particular, the test's not done, it's just binned. So it's getting those basic things right to try and improve things for all of you. And at the same time, I don't know if Gillian Ray is here, I think she was planning to be from genetics, but at the same time, the nursing staff will do a test for TTR genetics and send that off to Dr. Ray and I'm Shirley Hegarty in the genetics lab in Belfast to get checked for the TTR variants. Now, Mary was saying about the experience in London with lots of different genetic forms, with sort of the three main ones. I only ever see T80A here. So we have 100% T80A in patients who have had sort of parents, grandparents born in Ireland. The results from all of those tests then come back to me and I'll send letters out to all of the patients. I'll refer on to haematology if they've got clearly issues with, we think they've got AL amyloid. So that's a two-way street between, well, with most specialists, a two-way street between me and them for AL amyloid. But a lot of those patients will get cardiomyopathy, so I will still be seeing them. But a big thank you to all of the teams who make those tests happen so quickly. So the next step, if I get a patient with, and I'm suspecting TTR amyloid, will be a DPD scan. And again, Prof. Riley has explained this to you. So if you look at the that's not working. If you look at the one on the right side, so there's massive amount of DPD uptake in the heart in this patient compared to their skeletal system. Whereas on the other side, you've no uptake on the heart when you've grade 0. This is a thing called the Perrigini grading system. And then in between, you've got slight increase in heart and an increase in that. But most of the TTR patients that I see will have grade 2, grade 3 Perrigini scores, which always make, it's always easy when you're on one or either side of the variant, and the middle bit's not so easy. So DPD scanning, again, this is probably, and again, it's not my success at all. It's through the thanks of the radiology services locally. But we have a well-established DPD service here in Altnagelvin, but we're the only service at this stage in Northern Ireland. So if you are diagnosed with query TTR in any other trust in Northern Ireland, you can only get your DPD scan in London, which is an absolute disgrace, but that's the situation that we're at the minute. I've applied for funding locally. Myself and Dr. Alison Muir have a business case nearly ready to go with our service managers. Ideally, I would love to, this would be a regional service for Northern Ireland and a service for the patients in Donegal. Again, it makes no sense for people to be going hundreds of miles to get a bone scan. But and if it was in my doing, in my gift, it would already be happening. So who do I book a DPD scan on? Again, I can't flood the radiology service or I lose this service completely. So I have to have a very, very tight eye on. Nobody gets a DPD scan in the Western Trust without it going through me, so that I know that there's justification from the radiologist's point of view. So I'll use it in patients where I think there's a very high likelihood that they have TTR amyloid. I don't tend to send AL amyloid patients for a DPD scan. Because we know about 10 to 20% of AL amyloid patients will have some cardiac uptake, but the AL amyloid patients really need a tissue diagnosis to make that diagnosis. So in a service where I have a very limited pot of scans available, I don't want to be using them on people where I don't think it's going to alter or change their management pathway. And again, it wouldn't be possible without the help of my colleagues in radiology. And I also screen first degree. So if you are a first degree relative and you carry T80A, you will get a DPD scan here locally as a baseline. And again, it's because we're only really at the start of this. We have actually quite a lot of asymptomatic carriers locally, but they're all getting DPD scans. And the plan at this stage is to update those DPD scans in, say, 2-3 years or sooner if they get symptoms. But I'm aware of the fact that the guidelines on that may change over the next year or two. And if we could offer, if I was in a position again to offer treatment to asymptomatic carriers, we would do so, but we're just not there yet. So the next step then, so you've got a firm diagnosis, or you're a patient with TTR amyloidosis. The next step, ideally locally, and we are nearly there, but we're not quite there yet, are the virtual meetings with the team in the National Amyloidosis Centre. As I said, the business cases are. I have gifts in life. Writing business cases isn't one of them, and I do need people to help me with that. But they are being done. Ideally, what we would see then is a monthly Teams meeting with Professor Gilmore and his colleagues, myself, the cardiologists and the neurologists, etc. locally. We would present all of the results on the patients, review everything, make sure we're all happy with the diagnosis, get a treatment plan, get follow-up arranged locally, get all the scripts for medication done locally, and then plan follow-up. So that would mean that if you're a new patient with TTR amyloid locally, you potentially would not need to go to London. And existing patients to the service wouldn't need to have the reviews done in London. Now, I've had some patients saying to me they quite like their wee trip to London every year, and I would say, lovely, go to London and go to the Tower of London, go to visit Windsor. Don't be going to go to the NAC. That's, that to me wouldn't be a nice way of going to London, or go and see a show or something. But at the minute, again, hopefully this will change. But at the minute, AL amyloid patients would still need to make the trip. But we'll see what we can do. Now, I in no way. And I'm not just saying this because he's sitting here, I in no way want to take away from what Professor Gilmore and his team and Professor Fontana and the team do in London. I am in nearly daily communication with these people, and it's unidirectional. It's normally me asking them for help, either by email or via phone, and they are so good and so accommodating. And I do thank you, Julian, for all of the help that you give to all the patients locally and to me. Thank you so much. So what do we do? Again, Mary's touched on this about medication. So all the patients locally, and I'm informed it wasn't the case in Donegal, but it now is, all the patients who carry, so if you carry T80A variant TTR and you meet the clinical criteria, they've all switched from patisiran to vutrisiran. And that's medication that they, in simple forms, that reduces TTR production, basically by silencing the gene that makes the protein. Now, vutrisiran has been a real game changer for patient care. It's given 3 monthly in your home, in the patient's home, by Lloyd's nursing staff, and I give great thanks to them as well. It's so much easier to administer. I'm no longer getting the emails either from the NAC or from patients or Lloyd's going, we can't get any venous access and we need to get PICC lines in and we're going to delay therapy. So that is, my goodness, that has so much helped everybody. And it's extremely well tolerated medication, and it's really, I can't think of a single person locally who's on this who hasn't found some benefit to it. And then the other big change from when we chatted last is that we now have tafamidis available on the NHS. With real problems, and many of you in the room will know this, where you were getting diagnosed with your TTR, your wild type or variant with cardiomyopathy in the NAC. A lot of the teams in the NAC, again, I don't know the geography of Italy, and a lot of these guys are Italian and don't know the difference between Northern Ireland and the Republic. And tafamidis was available in Donegal, so these people were a lot of you would have been told when you went home, oh, you'll get tafamidis when you go back and you'll get tafamidis. And I was having to go, no, you can't get tafamidis. So it made me like the big bad wolf. But thank goodness we have been able to give this from last year. And again, as Prof. Riley has said, TTR exists in health in a tetramer, as 4 units together circulating around. In amyloidosis, that structure breaks down and you get a lot of these monomers lying about that then the body has to aggregate and store, which is the main problem. And TTR, or tafamidis, stabilises the tetramer. It's an oral medication, 61 milligrams for cardiomyopathy, given once a day. We use it for I think there are a tiny proportion of patients locally who have variant TTR, who have no neuropathy. Again, I'm sure if we looked hard enough for it, we would find it. But at least I have something to give those patients in the interim. So, but as Mary said, most T80A patients have a mix of a systemic issue, of a mix of both, and big issues with. I haven't rarely meet any patients with T80A who don't have significant autonomic problems, significant GI problems when they present. And it's the first medication licensed for cardiomyopathy due to wild-type amyloid. So that, again, has been a real game changer to be able to offer those patients something. But there are lots of newer medications coming on the market over the next few years. So it is going to be an issue of watch this space over what we do. But it's really exciting. I mean, don't forget, and I've said this to groups before, in my working lifetime, we've gone from having nothing to having all of this treatment. So we are so lucky. There are issues with the medication. This is not a simple matter of me writing a script and sending it, emailing it now to your GP, and and you go into, as you know, going to the chemist and getting it. The scripts have to all be issued through myself locally. All the updated scripts. If you're on tafamidis, I'll get a warning now electronically to say that you need a new script. I don't, with all the will in the world, again, I don't have the ability to follow all of that up myself. So Orla Traynor, our interface pharmacist, really does an awful lot of this work, and I'm indebted to Orla for all of the work that she does in this. So finally, things are improving a bit. We're trying our best to get things more settled and slicker locally for you. My big aim is to reduce the diagnostic delay for symptomatic patients and to increase the diagnostic pickup. And we have now, even in the last 6 months to a year, we have a lot of families locally where we've been doing genetic screening, and we'll be then following up those people as well. I know, despite that there are a lot of people, particularly in Derry and surrounding, who carry T80A that we haven't picked up. And the reason I know that, and I can be so sure of that, is like many of you, I grew up in an area where you knew everybody, you knew every family. I was related to half of them. The other half that I wasn't related to, I probably was related to, I just didn't know it. And my mother, God rest her, Mummy came from a wee village about 6 or 7 miles away from where my dad's family lived, and Mum was a blow-in until she passed away 50 years later. So that will not be unique to me. There's a lot of you will have grown up in townlands like that. And of course things are changing a lot in Ireland over the last 10 to 15 years. But we know that our genetics are very, very well. We're not particularly genetically diverse. And the Irish genome studies showed that the only 2 things in Irish history that have made any real difference to our genetics were the Viking invasion, which happened in the 8th century, and the plantation of Ulster, which happened in the early 17th century. So apart from that, 70 to 80% of our genetics is pre-Viking. So if we know T60, T80, sorry, that's automatic. If we know T80A comes from way back in somewhere in some person in the northwest, then it only stands to sense that there will be a lot of that carried through in the gene pool locally. So we'll continue to do our best, onwards and upwards. Thank you so much for your time, and again, thank you to particularly all the patients. Thank you.